International Talent Program. We're honored today to have invited 5 distinguished experts with us. The first speaker is Dr. Eric Alexander, Chief of Thyroid Section, Brigham and Women's Hospital, and Professor of Medicine at Harvard Medical School. Joining us today during the panel discussion session are Dr. Guang Haixia, Professor of Endocrinology and Deputy Director at the Department of Endocrinology at Guangdong Provincial People's Hospital. We're also honored to have Dr. Tianan Guo, My sincere apologies. I seem to have gotten offline, so I'll pick up where I left off. We're also honored to have Dr. Tianan Guo, PI from Westlake University, and Dr. Yaoting Sun, a postdoc at Guomics, who recently graduated from Westlake University with numerous honors. She has been with Dr. Guo's lab since 2017. Last but not the least, we have Dr. Shi Xiao, who is an MD at the Department of Head and Neck Surgery at Fudan University Shanghai Cancer Center. Without further ado, let's welcome Dr. Alexander giving us a talk on improving thyroid nodule care through molecular analysis. Welcome. Thank you.
Well, thank you very much. My name is Eric Alexander. It's a real honor and pleasure to present here at this conference on behalf also of all that Westlake University is doing. It is a pleasure to speak to you today on molecular analysis as it relates to thyroid nodule care and to give you really an overview and an update as to the current year, 2022. I always begin by saying that I've been very involved in this space, also with industry over the last decade, though I hope to be able to give you my independent thoughts on the very unique decade that we've lived through. The outline here is that I would like to talk about really the past, present, and the future, talking about why we feel molecular diagnostics have been important, where are we at in 2022, and really an idea of using molecular data differently into the future. I like to always ground this with a typical patient, and this is likely a patient you will have seen in the last few weeks or may see in the weeks ahead. A 48-year-old female found to have an incidental thyroid mass because she had a CAT scan for a different reason. She's asymptomatic, she's never had thyroid problems. She's in good health, appears clinically euthyroid, and on exam, a 3-centimeter left-sided nodule is noted. Her TSH is normal, and she's not on any thyroid hormone supplementation. This is a very common scenario, and for most patients like this, we would move forward diagnostically with a fine needle aspiration. In fact, that process, that diagnostic approach has been likely the standard for nearly 50 years. When we believe a nodule is clinically relevant, which means larger than 1 to 1.5 centimeters, we pursue ultrasound, we often check TSH, but for the vast majority of patients, 95%, we head towards the bottom right of this slide to ultrasound-guided fine needle aspiration. The benefit of FNA is that 2/3 of patients are found to have a conclusively benign result. There are no malignant cells. But of course, the problem of this simple procedure is that about 20% are so-called indeterminate, often referred to by their Bethesda staging. And the problem that I think we all know is when we look here at our data, which we just published 2 years ago, looking at a consecutive cohort of nearly 20,000 patients with nodules, you look at the Bethesda category on the left, and then if they were taken to surgery, the proportion cancerous on the right. And despite recommendations for surgery, we know that many patients are still going for benign disease. That has been the background to why we ask ourselves, can we do better through the use of molecular testing? As we talk about molecular diagnostic tests, I like to begin using this figure, in large part because of the simplicity as to how it describes cellular biology. that DNA is transcribed to RNA, which is translated to a protein, which does the job of the tissue or the organ. And we've now also long known that there is an inhibitory group of microRNAs that inhibit this last step. Now, this oversimplifies cellular biology and also even now the clinical translation, because there are many other new molecular processes and targets that are being looked at. But nonetheless, if you go back a decade ago, we began to see molecular diagnostic tests in each of these categories. Let me walk through them. The earliest is likely protein staining, that we learned that proteins such as galectin-3 associated with malignant disease more than benign disease, and you could begin to look at that. If you look now at more recent data, including data out of China that look at the metabolome, the metabolomic profiles, that really is similar to protein expression profiling. And so I think what is old is kind of becoming new again, and it's exciting to see this. We also have a series of tests looking at microRNA patterns. The idea that these microRNAs are fairly constrained. There's only about 1,000 in the human genome, but they tend to associate with benign or malignant disease. So could you measure some portion of them? And there's a signature that can be either benign or suspicious or malignant. In the United States, this has been taken forward by a company called Interpace, who has the most active product in the US called Thyroid or Thygenics. But there are many others looking at microRNA profiling as well. But the longest history in terms of active use in the clinical world has been looking at RNA-based tests and then DNA-based genomic profiles and how they might be used diagnostically. I will speak really again from the United States experience, acknowledging that many countries, including China and much of East Asia, is looking at separate ways to leverage these scientific processes. RNA here is the idea that you can look in any cellular tissue at all expressed genes, all 22,000, and in doing so, perhaps a pattern can fall out that describes, again, a benign or malignant process. The benefit of the RNA-based approach is the extent of genomic profiles, hundreds and thousands of transcripts looked at together, and also the ability for it to continually, iteratively improve. There's an artificial intelligence approach here that will allow it to always ask, what did I miss on the last one, and what other new transcripts can make things better? And then, of course, the DNA-based tests have long been in front of us, ever since the understanding 15 years ago that BRAF V600E was the causative oncogene for papillary carcinoma. The idea surfaced that you could look for these various mutations in indeterminate cytologic nodules, and they could be helpful. And the various tests have improved. In the United States, we have a version 1, a version 2, most recently version 3. It goes by the trade name ThyroSeq. And what they often were doing initially is adding more DNA-based mutations into their profile or rearrangements. But you'll note in the third version of the test that they also added an RNA-based expression unit, which I think is telling about the power of RNA-based expression, and I'll come back to that. But I do want to also say how the field is moving forward. It's not as simple as just DNA-based gene changes, because there are also structural DNA changes being looked at. Data out of Taiwan just very recently asking the question, cancers tend to lose their genomic integrity and take on different shapes, these so-called G4 structures, really a cutting edge rethinking of how DNA can be looked at for diagnostic purposes. But when we think about the translation into the clinical world, there's been a rapid maturation over the last decade, from discovery to analytic testing to validation, and now to really clinical utility understanding. And you may ask, what is the clinical utility? What does that mean? What it means is we are really looking very actively in 2022 for how these diagnostic tests are used in our diverse and real world. Is the test performing, and is it trustworthy as you would expect from its published data in your practice? Many people have long said, isn't clinical validation and the high quality study the most important? And the answer is yes, it's absolutely important, but it falls short because increasingly we have many clinical validation studies that are being performed and published, but there are really no blinded multi-center head-to-head comparable trials. No trials where 2 or more of these diagnostic tests are performed on the same nodule to help us understand performance. In fact, in the United States here, if you look at what has been coming online over the last roughly 5 to 7 years, these are really the 5 or 6 high quality phase 3 equivalent studies, prospective randomized multi-center. And you may often ask, as I get asked, well, tell me which one is the best. And as we often design these tests to maximize their negative predictive value, you may actually think the bottom one here, Rosetta's study, is the best, but that study is no longer available because the performance was not really as reproducible in the real world as was desired. So commercially, it was just not a success. And so that really is a lot of data just describing the last decade of this interesting field. That the discovery of molecular markers is clearly a benefit and helps us predict benign or cancerous disease, but also the study of this field has helped us understand just how diverse the real world is in terms of thyroid nodularity and its pathology. We really do need these high quality so-called phase 3 trials. But the problem is with all of the trials we have no head-to-head comparisons. And that really does not allow us always to understand if there is a single best test. I will share with you just some pathways forward. What is it that I look for in the current era for helping me through this, to understand which test to use, and also what is some kind of cutting edge next steps ahead as we think about 2022 and beyond. I think it's critical that we understand how uniquely different the Hürthle cell neoplasia nodules are, whether they are Hürthle cell adenomas benign or Hürthle cell carcinomas. These data, now published about 3 or 4 years ago by Raj Gopal at the Broad Institute and Ian Ganley at the Sloan Kettering in New York City, really opened up our eyes to saying that Hürthle cell disease is genomically different. They have mutations in their mitochondrial genome and also very large loss of chromosomal segments. And I say that because any diagnostic test would want to make sure that these data are rapidly included into their platforms. In the United States, we really only see 2 platforms that are useful, the Afirma platform and the ThyroSeq version 3, hence why those have been the most popular of tests in the US. But I also think the data are pushing us to say that RNA-based expression tests are clearly the key and the leading platform forward. Why is that? Well, remember that we're here trying to assess the problem of indeterminate cytology, and within that category, really only the Bethesda 3 and 4 based nodules. And it's important to ask what histologic processes make up those categories. And we know that there are clonal populations of benign as well as cancerous disease. We know that those nodules are also at times hyperplastic processes or cellular processes influenced by their background, like the inflammation of Hashimoto's. The reason that they are often atypical and classified as Bethesda 3 is because there are other factors that are influencing the cellular appearance: growth and stimulatory pathways, inflammatory processes, cellular repair, or immune regulation. The idea, of course, is that those are pathways, and the most logical approach to pick up on pathways that are impacting cellular appearance is likely RNA-based expression. There's no single gene mutation. There's not one DNA-based change that will signal inflammation broadly in the thyroid. It's a process of a much more complex genomic pathway. You could also look at it the other way and ask, why don't we just identify those DNA-based mutations? Well, the answer is complex, but I like this study, now published about 5 years ago in Nature, where the authors looked at patients uniquely who had a benign nodule, a malignant nodule. They also biopsied and genomically profiled the normal thyroid and then also the germline. And what they began to show, of course, is that benign nodules, perhaps not unexpectedly, show DNA-based mutations just as much as cancerous nodules. But we don't understand which of those mutations are purely cancerous and which are benign. While we do have the thyroid cancer gene atlas that tells us the oncogenic drivers of 300 papillary carcinomas, many of them, it appears, overlap with the benign nodule drivers as well. And the best example of that is looking at the RAS mutations. We had picked up on a signal early on with this proof of concept studies that we performed now in 2015, showing that of our nodules that were shown to be RAS mutation positives, it turns out that about half of them were benign and acting benign long-term. That has now been shown to be the case. And I like to quote this very large meta-analysis done by Martha Zeiger's group when she was at Johns Hopkins that showed the same issue, that when you look at 60 high-quality studies, RAS-positive nodules are benign half the time. And that's very important because we had previously assumed that everything RAS-positive was cancerous. That just isn't the case. So my feeling on this is that RNA-based instructions and RNA-based assessment is going to be the most powerful way to look at this field and improve diagnostic capability because of its ability to look at thousands of genes together to understand these pathways. It is no surprise that RNA-based expression is now part of the 3 available diagnostic tests in the United States, and I expect we'll find this forward. I'm going to spend the last few minutes of my talk, though, moving from diagnostics to prognostics to think about the future. As you know, molecular diagnostics have been very important because we know that they have helped reduce unnecessary surgery. Different data points over the last 30 years have shown that we are sending less patients with benign disease unnecessarily to surgery. We are sending more people with cancer for the appropriate treatment. But the molecular diagnostic tests, which we have just been talking about, do not inform us on how much surgery we should do, or inform us of the value of giving radioiodine or not, or how quickly we should follow up these patients. That is prognostic thinking. And in fact, when you think about thyroid nodule and cancer care and how to apply molecular knowledge, you can use it diagnostically, you can use it prognostically, or for advanced thyroid cancer, we can identify unique therapeutic targets or the appropriate tyrosine kinase to provide. But arguably, of those 3 big buckets, the one where we are in the most infancy as a collective group is using molecular data for prognostic care. When I was part of the American Thyroid Association national guidelines on thyroid nodule and cancer care in 2016, we had acknowledged that we simply do not think we can use molecular profiling yet. But their current guidelines coming out, likely within the next year, will likely think about this differently. And I'll end just by saying that we already had a signal that this could be useful from the thyroid cancer gene atlas itself. Remember, this looked at 300 very similar classical variants, typically, of papillary carcinoma. But even within that, they were able to show that there were 3 different groupings that seemed to behave differently. There were BRAF-like papillary carcinomas, there were RAS-like, and then there were the non-BRAF, non-RAS-like in the middle. And they behave differently. And in fact, many people would say, well, if you are a RAS-like tumor, though, don't you just harbor a RAS gene mutation? And that is not the case. I show you here those green lines, and you notice many RAS-like papillary carcinomas do not have mutations in HK or NRAS. Furthermore, many think that RAS-like tumors are all follicular variants, which would be the red lines, and that's also not the case. You see many here that are classical variants of papillary carcinoma, and yet still very low-risk disease. The idea here is that we are starting to increasingly use molecular data independently to become more and more prognostic and identify individualized risk. And I think we're going to see this more and more ahead. We can't do this commercially, clinically as right now, but we can likely do this in the years ahead with all of the data and expertise coming forth. In fact, we see this happening in other oncology fields. Thyroid cancer care is not leading the way. We know that in the United States, tests like Oncotype DX, Prosigna, they are helping prognosticate breast cancer. Decipher is a test helping to do the same for prostate cancer, et cetera. This is where we need to go also prognostically to help with thyroid cancer care. So with my appreciation for being able to speak to you today, the honor of being able to do it, and yet also the sadness of not being with you live quite yet, though hopefully soon, I want to give you my conclusions. I do think we're improving thyroid nodule care with molecular analysis. I think, though, you can also begin to see that molecular analysis of thyroid nodules are more complex than meets the eye. We have high quality validation increasingly being published looking at different molecular tests and different molecular tools, but arguably many of these are all very similar when you look at the publication. That is because, of course, we do not have direct comparison head-to-head trials. I do think we can come forth with some conclusions, though, that gene expression, RNA-based gene expression or microRNA-based gene expression is appearing increasingly superior to just direct DNA-based analysis, and I showed you why. There are many novel genomic approaches that many people are showing throughout the world. I like the idea of the G4 structure. We didn't talk much about metabolomics, but I think that's coming online as well. I did speak to you about the uniqueness of Hürthle cell neoplasia, and I also showed you why singular DNA-based mutations should not always be considered malignancy, like the RAS-positive lesions. We've historically used a very blunt approach toward thyroid cancer care, but you're beginning to see how molecular data can also be useful prognostically. That's what's exciting ahead. BRAF-like, RAS-like, these types of prognostic groupings are already starting to help us, and I think we're going to have more in the year or two ahead. With that, I thank you very much for the chance to speak to you today. It's an honor and a privilege. I wish you the best of health, and I do hope we can see each other live in the near future at a meeting or this conference once again. Thank you very much.
Thank you, Dr. Alexander, for sharing your inspiring talk. We now have a deeper understanding of how various old and new molecular diagnostic tools can better our care towards patients with thyroid nodules worldwide. We certainly look forward to having proteomics-based research discoveries as one of the leading tools in thyroid cancer diagnostics and prognostics going forward. We look forward to hearing expert opinions in the upcoming panel discussion. Dr. Guo, would you like to kick off the panel discussion?
Yeah, thanks, Bing. Well, Eric, for the very nice talk. Actually, we published a paper recently written by Yao Ting. So we find the Hürthle cell. If we look at the proteome landscape compared to the other tumor types, they are most of the proteins, more than 95% of the protein that's regulated, belong to mitochondria. This is a very interesting finding. Initially we didn't know why this happened, but you also mentioned several cancer cell papers. They studied the genome and they found the mitochondrial genome. And as you show in the central dogma slides, eventually this DNA mutation, RNA expression, they are reflected at protein level and execute their functions. May I ask you a question? So when you do the RNA profiling, which type of sample did you use? Do you use FNA, the fresh frozen, or can you do this with the FLP samples?
The question gets to the practical use of genomic tests. I think we really first, if I kind of think of the process of using genomic material for clinical care, I think early on, we were probably, if I go back 10, 15, 20 years ago, using basic proteomic staining really on histologic specimens. And in that sense, trying to gain almost a broader understanding of the uniqueness of a diagnosis or the prognostic processes. But that was quite simplistic a decade or two ago. Certainly in the last 10 years, I think the primary use clinically for in the thyroid world for genomic testing has been for this indeterminate cytology. So a lot of it has been coming forth really using the specimens obtained at the time upon finding aspiration, and for that help in determining the next step of a diagnostic process. Now, I think the more recent kind of world, as you heard in my talk, is clearly now looking again at trying to understand prognostically how do genomic understandings of disease help us understand treatment choices that lie ahead, the use of radioactive iodine, perhaps the understanding of a NIFT-P preoperatively, things like that. So I do think we're coming back to using genomics really on almost all specimens, not just aspirates, but also kind of fresh frozen samples or paraffin-embedded blocks.
I have published a paper with a colleague in Zurich, and we studied prostate cancer. We analyzed the RNA transcriptome landscape and also protein landscape in both fresh frozen samples and FFP samples. And we found that RNA is not very stable in FFP samples. So how do you have this practical issue in your test?
Yeah, no, I think as a general statement, DNA is much more stable and can actually be taken off of slides that have been fixed and older specimens. RNA certainly begins to degrade and so often has to be frozen early on, or a fresh sample has to be used. I still think in general, RNA holds the greatest promise because you begin to understand pathways and expression of the genomic code. But I do think you're absolutely right. It becomes much more difficult from a practical standpoint to obtain and analyze the specimen.
Yeah. So another issue is, do you have blood contamination during the FNA samples? If you take some sample from the needle, sometimes it's inevitable to have a blood contamination. Will that affect the RNA expression?
I mean, I think you're right. When we kind of think about a specimen, I think we inappropriately assumed it was always a homogeneous set of cells, and it certainly is not. That there's blood, even within a given nodule or a cancer, there is continual cellular genomic evolution. And there's some cutting edge data now that is really understanding the single cell sequencing and evolution within tumors to understand kind of why it's becoming refractory, things like that. Having said that, I think that the clinical testing of these, especially diagnostic tests, have been somewhat blinded to that. They go into it obtaining the sample and they test it on a blinded assessment. They iterate and improve with different RNA transcripts that are added to the test, and they test on a blinded secondary sample. So, in some sense, what you're saying is exactly right, though I think the field has kind of gone into it saying we will take all of that and still figure out what will prove useful.
Okay, so this is acceptable by the field. I mean, there's no way to, actually there's some way to remove the blood cell contamination by using lysis cover to lysis the red blood cells.
Yeah.
But the many part subject to RNA analysis.
I also have a technical question. I want to know how many punctures are required for clinical molecular diagnosis in America. For example, the CRC and the pharma. How many punctures?
Yeah. So. The story on how many needle aspirates are required to obtain an adequate full sample has been an interesting story. So just from the microscopic analysis, the cytologist will often try and obtain, as a rule of thumb, 6 groups of cells, each containing about 15 cells or more. So you put that together, and that's about 100 cells for microscopic analysis. And if you go back 2 or 3 decades, it used to be that as many as 5 or 6 needle sticks were often the standard. I think that's no longer the case, and I think we moved down to 4, and now I think actually as a standard we use 3 needle sticks just to obtain the microscopic cytologic specimen. For molecular specimens, generally I think you can get a good specimen with 1 additional needle stick. Now, many of the tests available in the United States will request 2. Because that's what they submitted to our FDA for approval, is that's how they obtained the most adequate specimen, and so that's the standard recommendation. But the ability to amplify genomic data, right, is very easy and very powerful. So you often do not need much as long as you feel it's from the adequate specimen.
Okay, I have another question. As we know, the FNA samples are evaluated by the Bethesda system, and if a patient has 2 different diagnosis results, one is from the Bethesda system, and if they got Bethesda 1, Bethesda score 1, and the other result is from the molecular test, they got a malignant nodules as the diagnosis report. How will you to decide to explain with the patient?
Right, a very good question. So we've increasingly seen this kind of paradox, which is there's I think a clear understanding of the appropriate use of molecular testing based on the best data we have, but there's also kind of the real world practical, real world scenario where at times patients will go to one place for one test and then go to another place for another test, and then they come to you with lots of data that is hard to interpret. The starting point for me, broadly, is the important acknowledgement that FNA cytology, a benign FNA cytology, classically a Bethesda 2, is a highly accurate and reproducible finding. So while there can be a rare extent of false negative benign cytologic nodules, it is very rare and ultimately often a very low risk tumor that was missed, and so likely a minimal long-term harm. What's important to know is that when you apply molecular testing on top of a cytologically benign nodule, you clearly can pick up on abnormal molecular signatures that can raise anxiety or suspicion, but ultimately don't necessarily change the way that one should think about the nodule. We saw that first when we were validating the test in the United States called Afirma, now about a decade ago. And remember, these tests are designed and then were iterated, were tested against really the Bethesda 3, 4, and 5 categories. They really were not meant to be tested on the Bethesda 2 or the Bethesda 6. And because, again, we've set that receiver operating curve to be highest for its negative predictive value, we knew then that there would be a sacrifice in terms of its positive predictive value. And that's what you then find when you start to apply it to either Bethesda 2 or Bethesda 6, is that you will pick up on some of these Afirma suspicious or ThyroSeq abnormalities, but you really want to kind of go back to understand where you came from, what your cytology was, and what the data first showed. So I do not like the idea of a standard approach that every nodule gets both cytology and molecular testing. I think that's probably not a smart move. We really want to use molecular testing, my opinion, where I think it's most valuable and also has been validated for success.
Okay. Another question is, I want to know in the clinical practice in the real world, does the cytopathology evaluation and the molecular tests are performed simultaneously or they perform sequentially?
Yes, and again, that gets to the real world use of the test. I think that comes down a little bit to your clinical practice. So, if I'll give you examples. If I had a patient who was traveling from far away, and so it was very difficult for them to come back a second time, I think it's logical to collect both specimens and just save the molecular one to see if it would be needed. I also think if you see, we should not exclude the importance of also ultrasound and sonographic risk assessment. And sometimes if I do see a hypoechoic nodule or some microcalcifications, I'm not sure, I'll probably have a low threshold to also obtain a molecular test in that moment. I'm not a huge fan, however. I mean, we see thousands in a year of biopsies and nodules. And so I'm not a huge proponent of collecting an additional specimen on everyone because that's a lot of extra needle sticks, and inevitably that causes more bruising and the patients just don't really enjoy it. And then there's also the storage complexity when you ultimately realize that still 70 or 80% of those nodules may well be benign.
Okay, I see. Thank you.
Hey, Eric, you mentioned that in the States, you only do this for the tumor with a size higher than 1 and 1.5 centimeters. Is that true?
Yes, generally, I mean, there certainly is a movement in the field based on data, originally out of Japan, right? That was suggesting that the non-operative management of small papillary carcinomas seemed equally as safe. And for those rare papillaries that were growing, so-called rescue surgery 6, 12, 18 months down the road seemed equally safe. Now, I think that has pushed the field to kind of ask the question, what about papillary carcinomas that are 1 to 1.5 centimeters? What about papillary carcinomas that are as large as 2 or 2.5 centimeters that show no abnormal lymphadenopathy? And I think the field is kind of wanting to answer those questions. I think that's going to be an important couple years ahead. But that really is what grounds us with who to biopsy, right? So we only biopsy essentially nodules over 1 to 1.5 centimeters based on those data that in general, it would seem safe to not know about a very small so-called micropapillary carcinoma. Just ignore it in a sense, because it really will not pose harm unless it were to grow.
Yeah, so in reality, when you take a biopsy, if you take a 1 needle punch, it may be placed under ultrasound guidance. But if you make it a second punch, it may be slightly different. It will be a different piece of tissue.
Yeah.
And in that case, the cytology, the molecular test, actually they're analyzing different tissues. Maybe they're very close. Maybe they're similar, but maybe they are not similar. Maybe one is benign, the other is more malignant. So did you have such a discrepancy in clinic, and do you have advice how to deal with this?
I ultimately think that when you do the biopsy, typically the movement of the needle is a good centimeter often, and sometimes in larger nodules, we move the needle 2 centimeters. And so while we certainly are not sampling the entire cellularity of that process, which is exactly what you are getting at, I still think we are grabbing hundreds of cells from different areas. And even though it is heterogeneous, I still think there likely is some, consistency and value in what we're obtaining. So it's an important theoretical question. I think rarely that impacts the current clinical world, but I think it's important what you asked.
Probably Haisha can comment on the clinical practice in China. I think according to my understanding, most people, they look at the mutations, BRAF mutation.
Right.
Yeah. So how many people are looking at that?
I saw Dr. Shi. Yeah.
Hi, Shi. Yeah, I would like to answer your questions, but different regions have different practice. I mean, in different hospitals, for example, at my hospital, actually endocrinologists perform FNA, and at the same time, when we do the biopsy, I mean, our endocrinologists, they will see the slides themselves to have the first opinion, not just depending on the decision of pathologists. So that's very different, because I know in some other hospitals, probably just the surgeons, they do the biopsy, and for some other hospitals, sometimes ultrasound doctors, they perform FNA. So it's very different. But in China, molecular markers are more and more popular, because sometimes in China we do not have very good cytologists. So some surgeons, they do not trust cytologists. So sometimes they want to add some additional evidence according to molecular markers. For example, if they say, okay, this is a Bethesda 1 or Bethesda 2, but the molecular markers indicate this is a BRAF positive nodule, they will, okay, the molecular markers made the right decision. It's not just depending on the decision of cytologists. So it's very different. And I think in China, we have a problem, because I think this problem is not cost effective, because I mean, not only Bethesda 3 and Bethesda 4 are sent to molecular markers. They sometimes surgeons or other doctors, they actually send all FNA samples for molecular markers. So it's unnecessary, but I guess for one reason is because they do not trust the cytology, and the other reason is they do not understand that actually the molecular marker can bring to us. Yeah. And in current practice, most hospitals, they use DNA-based molecular markers. For example, the BRAF mutation is the most popular molecular marker in China, and sometimes some hospitals, they also use gene mutations panels. It may contain several mutations, for example, RAS mutations, BRAF mutations, TERT mutation, and sometimes they also have other mutations, for example, the the NTRK mutation. I saw all kinds of mutation combinations in China. So it's another problem, because sometimes surgeons may have some misunderstandings. First one, they thought as long as there is a mutation in the sample, this sample means cancer. So we all know this is wrong, because RAS mutation, as indicated by Eric, RAS mutation represents a lot of benign nodules. And the second most, I guess, not most, but quite a number of surgeons think BRAF mutation means aggressive cancers. So it's another, misunderstanding. And the third, for medullary cell cancer, I guess probably Dr. Shi will talk it later. And some doctors, they do not know. For medullary cell cancer, they not only need to detect a germline mutation, they also need to, sometimes they need to detect somatic mutations in samples. So I don't think all doctors know this kind of, how to use mutations for our practice. So I think we need educations in China to let them know what will molecular markers bring to us, bring for our practice. And also we need to understand, RNA-based panels and DNA-based panels, protein-based panels, what's the advantage and what are the disadvantages? How about the cost effective? Because in China, sometimes we know, surgeon, operations is not expensive in China, not like in the United States. So we cost a lot of money. For example, a big DNA-based panel will cost us about $1,200. But for operation, it's just the same price. So yeah. So what's the point to get so many molecular markers? And also we want to know what kind of markers can bring us a prognostic, information as much as we can obtain. And my last comments is, as far as I know, panels used in China, they do not have blinded validation. That's another, problem, just indicated by Eric as well. So I think we need to design, good studies to validate these panels or these molecular markers. That's all my comments. Thank you so much.
Thank you. So Eric, you mentioned a few times that we need head-to-head comparisons. Do you have comments about what experiments or what trials can we plan to make that happen?
Right. I think the ideal trial would be obtaining, 2, 3, or 4 samples from the same nodule at the same time, and kind of independently then performing 3, 4, or 5 different tests, molecular tests. Ultimately, the hope is then followed in most cases by surgical resection and kind of histologic truth. It's a hard study to pull off because, certainly industry-sponsored tests would not be eager to sponsor a competitive comparison of those tests to each other. And so that's what's, I think, holding us back a little bit. But I do think that that would be interesting when and if it happens.
Yeah, maybe we can plan something along this line. Okay, we have Dr. Shi Xiao here. So he just came back from patient care. Probably it's time for him to give a talk. Are you ready?
Thank you, Dr. Guo, Professor Guo. I'm ready now and can share my screen.
Okay, thank you. Please go ahead.
Can you see this, my PPT?
Yes.
Okay, let's begin. Thank you, Professor Guo, for the invitation. I'm Dr. Shi Xiao, a resident from Department of Head and Neck Surgery, Fudan University Shanghai Cancer Center. Today, I'm very delighted to share my research findings here. My study title is Integrated Proteogenomic Characterization of Medullary Thyroid Carcinoma. Our study aims to characterize the integrated proteogenomics of MTC, which can help to gain functional insights into genomic aberrations and facilitate the exploration of proteogenomics-based therapies, and also called the treatment strategy-based therapies. This page briefly shows the contents of my presentation. Each of these parts listed here will be present and discussed in detail below. First, I would like to briefly introduce our study cohort. In 2020, we decided to do a large cohort research of MTC, and we are trying very hard to collect the samples from 109 MTC patients. All these samples were fresh frozen samples, not FFPE samples. All these patients received initial surgery, not after recurrence that he or she received next dissection. These patients were from 5 large Chinese tertiary hospitals in our collaboration group called the OTTA. And after screening and after our selection process, our final study cohort included 102 MTC patients. We can see the study relatively strict selection process in the left figure. Let me briefly introduce our study cohort. After the median age at initial surgery of our cohort is about 50 years old, and we can see the right panel. There were no apparent differences in the two genders. The male patients and the female patients are almost equal, almost 1 by 1. And after based on the family history, clinical manifestation, and germline red mutations, we found that a total of 25 patients were confirmed to be hereditary cases. This included 23 patients who were MEN2A or MTC, and only 2 patients were MEN2B. And both the two MEN2B patients were confirmed to have a germline red M918T mutation. And during the follow-up period, about 25 patients with a proportion of 24.5%, 25 patients developed into structural recurrence, or they have structural persistent disease. And 54 patients have biochemical recurrence, and or they never have a calcitonin back to the normal level. We called he had a biochemical persistent disease. And 15 patients developed into advanced disease. The advanced disease included locally advanced or included distant metastatic disease. We can show this panel. This is the upper panel is our part of our figure A. We would introduce the proteogenomic profile of our MTC cohort. For all the 102 patients, all the samples were tested for WES, also called whole exome sequencing. And all the 102 patients had tested for global proteome mass spectrometry. Only 1 patient was excluded for RNA-seq, or in another word, 101 patients were tested for RNA-seq. While 78 patients or 74 patients were tested for DNA methylation array or phosphoproteome MS, respectively. Using RNA-seq data, we use a package called Estimate. There were a very high tumor purity across the whole cohort with a median value of 91.5%. And across the 5 contributing hospitals, as our samples were from different hospitals, PCA analysis must be performed to show if there were batch effects. And the results showed there were no observable batch effects detected across the 5 contributing centers. And we also performed sample correlation analysis. The sample correlation analysis across the whole cohort were performed within different omics. Here we can clearly find out a higher consistency for RNA-seq data than the proteomic or phosphoproteomic data. And while predicting protein complexes in the quantum database is a very large database with a very huge information of protein complexes, we found that global proteomic data very well outperformed RNA-seq data. This results showed that protein level regulation may be better reflect tumor heterogeneity and gene function compared with that of transcriptomic profiles. We can also see the different RNA and protein correlation. We can see that 43% and only 1% of the 6,454 mRNA protein pairs displayed significant positive and negative correlations respectively. And we can see that in the right panel, genes involved in some metabolism-related pathways, including glucose metabolism, fatty acid metabolism, and other something like that, had stronger correlations. And those involved in oxidative phosphorylation and some large protein complexes, including proteasome, RNA transport, and protein export and ribosome. These large protein molecules, also these relatively corresponding genes had revealed poorer relevance across the mRNA and protein level. and the sample level, we can show that if the in general, mRNA protein correlations tend to decline with the increase of TEM staging. If the patients were confirmed to be an aggressive tumor, this patient, the sample, maybe have a larger chance to have a lower mRNA and protein correlations. Maybe it can be explained by a stronger protein level regulation and post-transcription regulation process. Next, we would like to introduce our landscape of driver mutations in our Chinese MTC cohort. As we talked about, a total of 25 patients accounting for 24.5% were regarded as MAN2. This was almost consistent with the data in Western or US MTC cohort, MTC patients. And most of the hereditary cases, the RAT mutations were clustered at codon 634. It was also worth noting that 2 cases from this group harbored germline RAT M918T mutations, and as we mentioned above, these 2 patients were confirmed to be MAN2B. And the 2 MAN2B patients, we checked their clinical data. The 2 MAN2B patients both have the presence of mucosal neuroma together. Both the 2 patients has mucosal neuroma, and 1 patient had pheochromocytoma, and 1 patient also have muffinoid body habitus. And excluding these 25 patients, the remaining 77 patients in our cohort were confirmed to be sporadic cases. This was examined by the clinical manifestation, and they have no germline RAT mutations, and they also have no any other family history of the MAN2. We can show that in most sporadic cases, we detected somatic RAT and HRAS mutations, and the most hotspot mutations in the RAT occurs in the M918T, the gene mutation, and the most hotspot mutation spot in HRAS occurred in the Q61. This spot is the most frequent mutation spot in HRAS. And as expected and consistent with the Western cohort, we can see a strikingly mutual exclusivity between the RAS and RAT and RAS mutations. This is also shows that RAT or RAS may independently cause the pathogenesis of MTC. And we also analyzed the dark matter cases. The dark matter cases means there was no any other driver gene or driver alteration in the genome. The dark matter cases in our study cohort, in our MTC cohort accounts for about 8.8%. This is very low compared to 18.3% in a previous study published in Cell Press member journal called iScience. So in combination, RAT mutations were responsible for 75.5% of the carcinogenesis of the MTC in the whole cohort, in combining the hereditary cases and sporadic cases together. We can see, well, next we would deeply investigate the RAT mutation. We can see, consistent with other studies before, the RAT M918T mutations had elevated tumor aggressiveness. This included a larger number of metastatic lymph nodes and more advanced TM staging, and a very higher chance of structural recurrence. And beyond RAT and RAS, there were currently no commonly identified recurrently mutated gene in MTC. But in our study, we found that 2 patients had BRAF mutations. These BRAF mutations does not occur in the most common hotspot V600E. Rather than that, we found that BRAF mutations, 1 patient, the BRAF mutation occurred in G469A, and 1 patient had BRAF mutation in T599 duplication. These two mutations, although not very common in other pan-cancer cohort, these two mutations, both the two mutations, were confirmed to be a driver gene in other cancers, including lung cancer, including pancreatic cancer, and including other neuroendocrine cancers. Next, we also calculate a BRAF score to further show the functional insights of these two BRAF mutations. The BRAF score is derived from the 2014 Cell paper, the TCGA paper, and also modified in our previous Nature Communications paper. We can clearly show in the bottom panel of this figure. We can show that the patient's FUSCC41, this sample had BRAF T599 duplication. This patient had a very high BRAF score, and another patient, FUSCC14, this sample had a relatively median BRAF score. This shows that the T599 duplication mutant strongly activates downstream signalings. It most likely resembles its neighboring hotspot mutation V600E. Beyond RET, RAS, and BRAF, we also find a very, very interesting case. This case is FUSCC24. This case is a very unique MTC case in our cohort. He had also had a concomitant neurofibromatosis type 1. This disease is also short for NF1. NF1 is a multi-system genetic disorder caused by pathogenic alterations in the tumor suppressor gene NF1. We found in this case, in his MTC tumor, we detected a de novo frame shift mutation. This frame shift mutation in F gene is also a truncating mutation. It will cause an early stop of the transcription process. And we can predict using the genomic data. We found this mutation may turn the codon 1113 into a premature stop codon. The stop codon happens prematurely. And to test this hypothesis, as we have RNA-seq data, as we also have proteomic data, we will test further test the function of this mutation in our both two platforms. We can clearly see in RNA-seq data that across all the patients in the cohort, this FUSCC24 sample, his MTC sample, tumor sample, has the lowest NF1 mRNA level. And as well, the mass spectrometry did not directly detect the NF1 protein abundance. Therefore, we can conclude that NF1, this truncating mutation causes the premature stop of this gene transcription. So we may find that this NF1 truncating mutation was identified a putative driver of the MTC oncogenesis. And we can supplement another detail. This patient does not have an identified RET or RAS mutation. That he did not have any other potential driver mutations. NF1 was the only potential driver mutations in his WES results. We can also tell you the variation allele frequency of this NF1 mutation. The frequency of this NF1 mutations is nearly 50/100. Is nearly about 48.4%. It's a very high. Shows that this mutation may be highly likely to be a driver mutation of this sample of MTC. After introducing our genomic results, we would like to show our proteomic profiling of our cohort. Among the 102 MTC tumors, we conducted unsupervised clustering, and using this unsupervised clustering, we identified 3 proteomic clusters with very distinct molecular features. And to be specific, cluster 1, accounting for 32.4% of all tumors, were named as the metabolic subtype. This group of patients was, as seen in the figure, in the left figure. This group of patients were characterized by enrichment of multiple pathways relevant to cellular metabolism, including the glucose metabolism, including the fatty acid degradation, or other fatty acid purine metabolism. And while the cluster 2, constituting of 35.3% of tumors, was classified as the basal subtype. The basal subtype show the protein-specific elevation of basal factors, such as eukaryotic translation initiation complex and CD44, PLAR, BCAM, and something like S100A14. And these basal factors were significantly upregulated in this subtype of tumors, so we called these subtypes as basal subtype. And the third cluster, constituting about 32.4% of all the cohort, showed very significant upregulation of ECM associated proteins and pathways such as collagen, laminin, and integrin, and other fibronectin, and other something like TNC or TNXB or SPP1. This type of tumors showed upregulation of these type of proteins, so we called this type as the mesenchymal subtype. Next, we liked the 3 different subtypes showed very distinct genomic, clinical, pathologic, and epigenomic features. As shown in the top left panel figure, we can show that rat M918T driven tumors were mostly enriched in the mesenchymal subtype, while the RAS driven tumors were enriched in the metabolic subtype. And also we can see that also metabolic subtypes shows the highest level of genome instability. They show the highest ratio of the CNV frequencies. And while the mesenchymal subtype were relatively stable, and the basal subtypes consistent with its best prognosis shows the most stable genome. And also, the mesenchymal subgroup might reveal a relatively higher level of DNA methylation. We can see in both terms of CpG shore or CpG island, the mesenchymal shows the highest level of DNA methylation across the 3 cohorts. And the pathway enrichment analysis revealed concordant regulation trends at the sDNA and methylation levels. The mesenchymal tumors showed increased level of angiogenesis, increased level of focal adhesion, while the metabolic tumors show the highest level of RAS signaling, the highest level of nuclear receptors. This is predicted by in silico analysis. So we concluded in this figure that mutations, copy number changes, and epigenetic modifications may together participate in the determination of MTC phenotypes. And these 3 subtypes also showed very different behaviors in the tumor aggressiveness. We can show in the top left figure, this is a Kaplan-Meier survival plot. We can see clearly that the mesenchymal tumors is the below line. It has significantly poorer structural recurrence-free survival compared with that of the basal subtype. The basal subtypes have the best prognosis, while the mesenchymal subtype have the worst prognosis. And also, in terms of TM stage and biochemical recurrence, we can see that the mesenchymal tumors had the most advanced TM stage. Most of these tumors were classified into stage 4. And the mesenchymal tumors also have a large fraction of biochemical recurrence. Most of the mesenchymal tumors have biochemical recurrence. Few patients, the post-operative calcitonin or CEA level remained stable in the normal level. And the summary, we can see that the metabolic tumors, this table 1 shows the many different aspects of the 3 subtypes. This table we will discuss in detail in the afterwards. Next, we will focus on each subtype. First, we would like to in detail discuss the metabolic subtype. We can see in the left figure, we found across the 3 cohorts, we found very significant enhanced MAPK signaling activities in the metabolic subtype. We used KEGG and Reactome. We the GSEA. We calculated an AES value of the MAPK signaling pathway. We found that the metabolic subtype had a significantly increased NES values of this signaling pathway compared with the other 2 subtypes. And also, using the phosphoproteome data, we also show our data also showed elevated phosphorylation levels at serine 16 and 14 sites on STMN1. This protein is a very important member of MAPK signaling pathway. So, taken together, we may conclude that the MAPK signaling pathway were most likely to be enriched in the metabolic subtype. Beyond that, we also find that some important proteins in the PI3K, AKT, and mTOR signaling pathway. This is the same pathway. We can see most members in this pathway were significantly increased in the metabolic subtype, such as AKT1, AKT2, mTOR, and BCL2 and CDK4. And we also calculated a PI3K signaling score, and we found that this signaling score is mostly is the highest in the metabolic pathway, in the metabolic subtype of tumors. So we may conclude that stronger activation of the MAPK and PI3K, AKT, and mTOR pathways may be an important biological feature, biological hallmark of the metabolic tumors, which warrants further validation and for their therapeutic values. And we also find there was a very significantly higher frequency of CCND gains and CDKN2A or CDKN2B losses. We also found this phenomenon in the metabolic subtype. We found that CCND is a positive regulator of the cell cycle signaling, while the CDKN2A or 2B were a negative regulator of this cell cycle signaling. This phenomenon, this CNV results showed that cell cycle signaling may be enriched in this metabolic subtype. To further validate this finding, we also investigate this phenomenon in the proteomic level. We found that many important important proteins in the cell cycle process, like CDK4, like PCNA, like RB1, was significantly increased in this metabolic tumors. And well, an E2F activity score is introduced in a cancer cell paper of head and neck cancers by CBTech. This score positively correlates with the cell cycle signaling. We found this score is also have the highest level of this score in the metabolic tumors. While some cell cycle signaling inhibitors like CDKN2C or E2F4 were lowest in this subtype. So we may conclude that a significantly increased E2F activity or increased level of cell cycle activity were observed or may be a biological hallmark of this metabolic subtype. And we also
would be appreciated if you can finish in about 1 or 2 minutes. How many slides do you still have?
Okay, we'll move faster. I will move faster. We also find that the metabolic subtypes show a higher HRD score, representing increased genomic instability And we also find the copy number losses and deletions of common DDR, DNA repair related genes in the metabolic tumors. The vast majority of these tumors with DDR related genes deletions will have a HRD, have a very high HRD score, most likely to be upper more than or equal to 42. And next, we would introduce the molecular feature of the basal subtype. We can see in this figure that the basal subtype had increased signaling pathway with some neuroendocrine features such as axon guidance, synaptic vesicle cycle, and calcium signaling pathway. This seems to show that the basal tumors may have a higher neuroendocrine capability. And furthermore, we found that the basal subtype had increased level of some very, very important neuroendocrine proteins, neuroendocrine markers, such as calcitonin and its analog calcitonin B and CEA. CEA is called, in the protein level, is called CEA-CAM5 and its analog CEA-CAM6. And in addition to that, we also find that the basal tumors had a significantly increased level of important neuroendocrine markers such as synaptophysin or chromogranin. These results showed that the basal tumors may have a higher neuroendocrine capability. The higher neuroendocrine capability may show, combining with this best prognosis, may show that this kind of tumor may well retain the biological feature of C cells. It may be better differentiated than the other two subgroups. And the drug target analysis we analyzed in silico analysis found that CEA-CAM5 is also called CEA, may be a potential drug target for this type of tumor. And next, last we would introduce further introduce the biological feature of the mesenchymal subtype. We found that the mesenchymal subtype had increased level of the most higher level of two proteins of the same family. One is called the TNC, tensin C, and one is called the TNXB. It's also called tensin X. And these two proteins also indicates a very, very strong, the higher level of these two proteins may indicate a very poor prognosis, whether either in the whole cohort or in the mesenchymal tumors alone. And we also validate this finding using the IHC, immunohistochemistry staining in our cohort. We found that the mesenchymal tumors indeed have increased level of TNC or TNXB validated by the IHC staining test. And we also find that the mesenchymal tumors had an enhanced STAT3 signaling. And most importantly, we deeply investigate the drug target of this mesenchymal subtype. We found that the key angiogenic factors PDGFRB and VEGFR1 is also called FLT1 were significantly upregulated in the mesenchymal tumors. Interestingly, the two proteins are not only drug targets for the FDA-approved TKI, cabozantinib, but also the targets of several other TKIs in clinical trials for advanced MTC, such as sorafenib, lenvatinib, and sunitinib, etc. So these two tyrosine kinase receptors are also target for allotinib, a TKI approved for the treatment of advanced MTC in mainland China. So we can conclude that some TKI may be a potential drug target for these mesenchymal tumors. They in silico analysis showed that they may have a better tumor response than the other two subtypes. We also find that a target for sorafenib is a Chinese developed TCI. Its target CSF1R also showed higher expression in these mesenchymal tumors. So at last, we would like to introduce the highlights and limitations of our study. the first highlights were we have a comprehensive proteogenomic characterization of 102. This is a very large cohort for MTC. We provide a very rich resource for future research, and the integrated analysis identify novel MTC driver genes, including BRAF and AF1. We also validated their downstream effects using our multi-platform data. And our proteomics data also reveals 3 distinct subtypes with genetic, epigenetic, and clinical pathologic and very different prognostic relevance. And our proteogenomic analysis also identifies potential therapeutic targets in each MTC proteomic subtype, although they need to be further validated. This table 1 shows the different aspects of our 3 proteomic subtypes, including the proteogenomic signature and other factors. The limitations is also very evident in our study. First, the MTC lacks mature tumor models for experimental research, including they have very, very few cell lines, lack of mature technology for primary cell line, PDX, or organoid model construction. There were no published literature yet. We have not found that. And the MTC also lack of other multi-omic study, including those uploaded to GSA or GEO. There were no public available sequencing data, especially proteomics data. These reasons above, the 2 reasons above, cause lack of validation for our conclusions, including lack of validation of our proposed proteomic subtyping and lack of validation for our drug targets. And this study is mostly proteome-centric. There was need to be a further exploration of our RNA-seq data, phosphoproteomic data, and methylation data. Acknowledgement, we think this study is now under minor revision at Cell Discovery. It's with impact factor in 2021 is over 38. And we also thank NSFC and the National Key R&D Program for funding support. And we thank contributing hospitals in the OTTA consortium. And we also thank Shanghai OE Biotech Cooperation for the assistance of providing sample sequencing and bioinformatic analysis. And we most thank patients' generosity in devoting their samples for our scientific research. This is my presentation today. Thank you very much.
Thank you, Dr. Shi Xiao, for sharing your interesting findings. Next, we'll have the second panel discussion for about 8 minutes.
Okay, I would like to close my sharing of table. Now is my table sharing closed now?
We can still see your presentation.
Okay, I would like to close the share, or we can start to discuss this.
Yeah, we can kick off the discussion for sure, just in case anyone's interested in one of your particular slides. It's helpful as well. So Dr. Guo can kick off the second discussion, please.
Actually, Dr. Alexander has to leave in about 7 minutes. Maybe I actually have some remaining questions to Eric. Maybe you can do that first, and then we come back to Dr. Shi's talk. Unless, Eric, do you have any question to Dr. Shi's talk?
I thought it was an extensive amount of analysis, so congratulations on all that you have done. And I really enjoyed the ability to bring together many different types of genomic analysis. I do think the 3 different metabolic areas, profiles, buckets that you were able to elucidate, that's really fascinating. And I love how you're taking it forward also into the clinical world with potential drug targets. So no, just congratulations. I found it fascinating to watch. I look forward to reading the paper.
Okay, thank you, Dr. Eric. We are planning to bring our study conclusions to the clinical use, but it's one of our limitations is that the MTC samples, MTC patients, this disease is a relatively rare disease. although we have a lot of thyroid operations in our center, and MTC patients, especially advanced MTC patients, is relatively few. We can see in our clinical trial, in our clinical practice, only less than 50 advanced MTC patients can be seen in our center or our other collaboration centers in a year. So we are currently planning a more and more extensive collaboration in multiple Chinese centers to do this, to bring this our results and our conclusions to further clinical use.
So just now, Eric mentioned the need of a head-to-head comparison of different tools or different molecular tests to diagnose thyroid nodules. We can do this, as Dr. showed, in a particular tumor type. There are so many differences at multiple levels: genetic, transcriptomic, and proteomic, phosphoproteomic, and maybe also metabolomic. So from a clinical point of view, so we certainly cannot afford to measure all these omics for a particular nodule. You have a very limited amount for needle biopsies. So from clinical point of view, what do you think will be practical? What do you think RNA measurement is sufficient, or do we need another complementary test to further improve the accuracy of a thyroid nodule diagnosis? Or some people may say, like Dr. Guan said, maybe many people think BRAF is sufficient, and they make a decision purely based on BRAF or RAS.
Currently, okay, this question for me or Dr. Eric?
You go first.
Yeah, you can go first. Yeah.
Please, Dr. Eric.
I think that's a great question, Jen. I think it is, impractical to think we can do molecular testing to this extent on every, clinical specimen, though maybe someday in the decades ahead. I think what's unique in the medullary carcinoma world, I think she also is seeing it, is that we understood early on that the somatic mutation, in particular in RET, was not only at times diagnostic, but was actually a very clear signature of a prognostic clinical profile. There were kind of medium risk mutations that were high, that were very high, and that was driving recommendations, especially in the familial syndromes, for when to consider prophylactic thyroidectomy. I still think that's very useful and practical right now, but I do think where we're headed here in terms of metabolomics certainly opens up a lot of options for.
Dr. Shi, do you have any comments?
In clinical practice, we may see a lot of thyroid cancer patients or suspected thyroid nodules in clinical practice or in some professors' clinical trials. But in fact, most people of them or benign thyroid nodules, or they have most likely to be papillary thyroid cancer. And especially in some small centers or small hospitals in China, and many doctors do not have the idea that they may test it for a thyroid function, including the calcitonin. And they think that they, in nearly their career or most of their career, they do not see even one MTC or ATC patient. Most of them are papillary thyroid cancer. They may think that testing BRAF or RAS, especially BRAF, is enough for the clinical use. In fact, in our center in FUSCC, we have a panel, a gene sequencing panel, similar to the US ThyroSeq version 3. We have more than one panel is consisting of 18 genes, and one panel we are taking into clinical practice it consists of over 180 genes. If it was not brown, consisting of more than nearly 200 genes. Using these genes, we can test the more accurately test the feature or if it was cancer or benign disease of this thyroid nodule. This panel includes RET or BRAF or RAS or some gene fusions or some even more rare, even rarer mutations or genes, such as including my data shows that NF1. So including these genes, we can better predict cancer nodule, the nature, the feature of this nodule. So so this is my comment.
Okay, so Dr. Guan, do you have any comments?
No, actually, I do not have any additional comments.
Your team?
No.
I think it's time to close this section. Thanks a lot for all your time. I think it's clear that the thyroid nodules still need more effort to make a better, better with more precise and more practical diagnosis in clinic. And certainly in China, there are so many misunderstandings according to what Haisha told just now. And in the States, there are also there are hopes that they can further be improved by head-to-head comparison in a future trial. I hope we can work together on that. And I think not necessarily select or compete each test among each other to have a complementary integrative analysis, which is cheap and fast and can be implemented with one or two needle punch, and which brings the patient less pain. Maybe this can be realized in the next few years. So I still have many questions to Eric and Dr. Shi, but the time goes very fast. Maybe we can further discuss in future events. Thanks so much.
Thank you.
Thank you. Thank you, Dr. Guo.
Thank you.
Thank you, Eric. Thank you, Yao Ting. Thank you, Dr. Guan.
Bye.
Bye-bye.
Bye-bye.
Bye-bye.